Welcome to Massey College. Bienvenue. My name is Nathalie Desrosiers, and I'm the principal of Massey College. It's my great pleasure to welcome you to this Senior Fellows Lunch, the first of the year, and so I'm delighted that we are all here back at Massey to engage on the very important questions of the day, and that's certainly what we will do today. And I think it's important and it's to recognize that the Massey College is built on Indigenous lands, the lands of the Huron-Wendat, the Seneca, and it is the treaty land of the Mississaugas of the Credit. We want to acknowledge our duty of stewardship toward this land and the great privilege that we have to continue to do our work here. So without further ado, I'll introduce Professor Jennifer Jenkins, who is the chair of the Senior Fellows Lunch Committee, to introduce our guest. Professor Jenkins.
Thank you, Natalie, and thanks to all of you. It's so great to see everyone here around a big table at Massey College, and welcome to this year's set of Senior Fellow Luncheons. And we're so honored to have Dr. Robert Bell here with us today, speaking about opportunities for Canadian healthcare, so a very timely topic. Do you go by Bob? Did I call you Bob? Okay. So Dr. Bob Bell served as Ontario's Deputy Minister of Health from 2014 to 2018. And prior to this role, he worked as President and Chief Executive Officer of the University Health Network for 9 years. He was previously the Chief Operating Officer at Princess Margaret Hospital, the Chair of Cancer Care Ontario's Clinical Council, and the Cancer Quality Council of Ontario. He received his Doctor of Medicine from McGill University, a Master's of Science from the U of T, and his fellowship in orthopedic surgery in 1983. Completed training in orthopedic cancer surgery at Mass General in Boston and at Harvard University in 1985, and the Advanced Management Program at Harvard Business School in 2005. So very well-rounded, sort of covering the whole spectrum from medicine to business. Dr. Bell is a fellow of the Royal College of Physicians and Surgeons of Canada, the American College of Surgeons, and is an honorary fellow of the Royal College of Surgeons of Edinburgh. Today, he provides advice to a number of private and public organizations and is on a number of not-for-profit and corporate boards. He's published 2 novels. I thought that was very interesting. That you've also published 2 novels, with a third expected in the fall of 2022, with all of the proceeds from these books benefiting the University Health Network. What is the title of the third book?
It's Jonah K.
Okay, so
Jonah K. We'll let Principal Desrosiers know when it's being published.
I know, and we do a book launch here.
Oh, that would be wonderful. Well, there's a virtual book launch in the hospital, but a book launch would be wonderful at Massey College.
okay, we can look forward to that. So we have medicine, we have business, and we have the arts. We have literature. Bob Bell's talk title today is Faster, Better, Smarter, Opportunities for Canadian Healthcare. If you could join me in welcoming him as our speaker.
Well, thank you. Isn't it wonderful to actually be sitting around a table in a public space and chatting with people again, without masks on and without, hopefully, that many concerns about viral contamination. It's marvelous to be here. Principal, thank you so much for the invitation. And, when you're thinking about big ideas to discuss at this wonderful venue, healthcare certainly serves as one of the things that Canadians are interested in. And we could possibly put up slides at this point. This talk is derived from a series of articles that I wrote with co-authors Ann Golden, who also is a collaborator with your principal, and is a former CEO of United Way Toronto, former CEO of Conference Board of Canada, with Paul Alofs, former CEO of Princess Margaret Cancer Foundation, Lionel Robbins, who used to run Dilex Corporation and was a chair of the Princess Margaret Cancer Foundation. And at the beginning of 2022, we all of us have worked together raising money for various social and health causes, being concerned about healthcare. We sort of thought to ourselves, gee whiz, we're coming out of this pandemic. What are the areas? And there was a tremendous conversation that continues to this day about the fact that Canadian healthcare is perhaps so broken that we need to drop our commitment to publicly funded healthcare. We need to leave behind the principle that care should be provided in Canada on the basis of need rather than ability to pay. Lots of editorials you've seen suggesting that we should introduce a two-tier system in Canada because our healthcare system is so broken, it requires so much money. The public purse can't provide the resources necessary for appropriate health care, for appropriate access to care. Therefore, we should look at changing the philosophy that's underpinned Canadian healthcare since the days of Tommy Douglas in Saskatchewan. And the four of us are supporters of public health care, and we thought, well, let's look at the way we're providing health care in Canada today. And how can we make care faster, better? I wanted to say cheaper. My co-authors convinced me that smarter was better than cheaper. But in point of fact, more cost-effective is perhaps even a better term. And Howard Clark and I were talking about some areas over lunch where cost-effectiveness is obvious. And you can see these 10 ideas. They're published in the Globe and Mail as an opinion series in the Globe and Mail. If you want to find them quickly, you can go to the webpage, Dr. Bob Bell, DrBobBell.com, and you'll find them listed there. You need to get inside the Globe and Mail firewall to get them, but probably through Massey College you can get inside the Globe and Mail firewall readily. So I'm not going to talk about all 10 ideas today, but I'm going to talk about an important cross-section. And when we think about the current reliance on our Canadian healthcare system and how we think about it coming out of the pandemic, what is the pandemic experience and how should that reflect on our estimation of how effective the Canadian healthcare system was? And realistically, Canada did pretty well during the pandemic. If you look at mortality rates and you compare us to most wealthy Western countries, certainly leagues better, 10 times better in mortality than the United States, better than most Western European countries. Inevitably, some of the scans beat us. Sweden did not, but Finland and Norway did. If we look at the isolated colonial Pacific islands of New Zealand and Australia that basically shut down, if we look at some Asian countries, Taiwan, for example, better with respect to mortality rates. If you look at uptake, public confidence in the public health system that led to people getting appropriately vaccinated and also provision of appropriate vaccines in a rational way, an effective way, we did pretty well. We did pretty well. We could have done better, no question. We could have done much better in long-term care where our seniors who lived in long-term care nursing homes, especially in central Canada, especially in Ontario and Quebec, had both a very high mortality rate. 80% of Canadian mortality during wave 1 and wave 2 of the pandemic were in long-term care homes. And we actually had the highest proportion of mortality in long-term care of any Western country because of some of the ancientness, if that's a word, of our long-term care in Ontario and Quebec especially in Quebec where long-term care with 4 and 7 people in a room simply spread the virus so dramatically amongst people who are extraordinarily vulnerable to it. So if we look at the pandemic and generally think about how our system performed, pretty good, but when it came to seniors living in congregate settings, we clearly need to rethink the way that we are providing care to seniors who are becoming frail, who are becoming cognitively impaired, and we'll talk a little bit about that. But as we come out of the pandemic and see where we are now, what are the recent headlines that you're all seeing that define Canadian healthcare and how much faith we can have in Canadian healthcare? And currently, those headlines are replete with stories of problems with access, stories of emergency departments being closed. In Perth, Ontario, emergency department closed for 40 days in a row because of an inadequacy of staff. And that's not something that we've heard. In Ontario healthcare and Canadian healthcare generally, this idea of structures that communities rely on closing down, not because of lack of money, but because of lack of staff, are new. We haven't heard about those. I think it's fair to say, Principal, during the time you were in Cabinet, that was never a story that hospitals were being, it was always hospitals are challenged, but it was not a story of hospitals, emergency departments are closing. So clearly that reflects a number of things. It's a perfect storm, perhaps, of people being simply worn out from the pandemic. People who are 60 and eligible for retirement from a nursing staff in an emergency department saying, I've had it. I'm going to go and do something else. I'm tired of the pressure that comes on. And clearly there's a health human resource challenge that's around the world right now. In terms of the baby boom peak starting to retire, the pandemic perhaps leading to retirement a bit faster, challenges certainly existing in health human resources. Those seem to be hitting Canada a little harder than other jurisdictions. And again, I'm going to compare us mainly to the wealthy world. If we look at international comparisons of how good Canada's health system has been over the last 20 years, you'd probably be surprised to know that we're not very highly ranked. There's an organization in the United States called the Commonwealth Fund that gathers information, as much information as it can, in objective data, but also a lot of questionnaire data that's provided to people who are being served by the system. And they look at 11 wealthy nations, the UK, Australia, New Zealand, the United States, France, Germany, Switzerland, a few of the Scandinavian countries. And of those 11 countries that they've reviewed year after year after year, for about 20 years now, Canada inevitably ranks second worst. Just ahead of, you won't be surprised, our wealthy neighbor to the States that spends about 80% more on healthcare than Canada spends and gets much worse results when you look at the totality of service across the system. However, we spend a lot of money. Surprisingly, we think of ourselves as a publicly funded system. We only actually spend about 68% of healthcare costs in this country are derived from the public purse, from taxpayers. 32% is provided by private insurance or out-of-pocket costs. The areas where the Commonwealth Fund finds problems with Canadian healthcare relates to two words. The first word being access, and the second word being equity. And it might surprise you to think, what, equity for us when it's publicly funded healthcare? Well, you know, you can't get access to medications in Canada unless you're fortunate enough to have a drug plan provided by your employer, or in some cases by government. You can't get access to dentistry unless you have employer-funded benefits. And in most of the wealthy world, both pharmaceuticals and dentistry and physiotherapy, and in many cases mental health services, are provided from the public purse. Not true in Canada. And we'll talk a bit about that. So access and equity. And I want to start off with the issue of access, because it's become also apparent. The other headline that's being written recently is not only access to emergency departments that are closing, but access to primary care. Let's move the slide forward one if we could. So I'd say the biggest problem that we have across the country, and I'm glad Jane's here because she's an expert on primary care, and I'm sure we'll have some comments, in this country is problems with access to primary care. And I'm going to suggest to you that one of the biggest problems we have is that medical associations, which essentially serve as unions for physicians, so Ontario Medical Association in this province, have convinced Canadians that every Canadian needs a family doctor, right? You've heard that. And you've seen headlines now that say that 20% of Canadians don't have a family doctor. And I think that is an interesting perspective. It's obviously good to capture as much turf as you can when you're representing a profession. But the fact that Canadians believe they need a family doctor, as opposed to needing a nurse practitioner, as opposed to needing a nurse, a dietitian, a physiotherapist, a mental health provider who may be a social worker, this is a bill of goods that Canadians have bought that makes it very difficult, but enriches the medical profession. I'm a physician. I'm an orthopedic surgeon. I've worked as a general practitioner before I went into orthopedics. And, you know, the thought that we need a family doctor for every Canadian hurts us. Because family doctors who have 2 years of training after doing 4 years of medical school, after doing 4 years of undergraduate school, do essentially the same task that a nurse practitioner can do after 4 years of undergraduate school and 2 years of training. So if you total all that up, it's 4 plus 4 plus 2, 10 years for a doctor as opposed to 6 years for a nurse. And nurse practitioners in Ontario provide care extremely well. There are a lot of nurse practitioners working in autonomous nurse practitioner clinics across the province who have some of the highest satisfaction rates of all the primary care providers that when I was in the ministry, we used to send out random questionnaires. The highest patient satisfaction we got back for primary care was from nurse practitioner-like clinics. So we've been sold a bit of a bill of goods. And I think that right now, when we see the problems associated with primary care, you know, a recent Angus Reid poll that was published September 8th, so 2 weeks ago, 3 weeks ago now, looking at over 2,000 Canadians, not just Ontarians, found that 50% of Canadians either did not have a primary care provider or said that, yes, I have a primary care provider, but I can't see them within a week if I'm sick. A week, you know, if you've got chest pain, if your child has a fever, if you've got abdominal pain, and you call up the office and they say, well, doctor's pretty booked, can't see you for a week. I mean, that's unacceptable. And where do you go? Jane, where do you go if you hear that from your family doctor's office? Your kid has a fever, you can't see your doctor for a week. Where's your next visit? To the ER, right? And, you know, part of the challenge of our emergency departments post-COVID is the number of people going there has simply escalated because so many doctors now either won't see their patients or what will they do? They'll tell you, well, doctor won't see you, but they'll provide you with a virtual visit, right? Say, a virtual visit? My knee's sore. You can't see me virtually. I can't show him my knee over the telephone. So primary care is in a bit of a mess in Canada right now. And I do consulting now across the country. This is the number one challenge. When we're thinking about making care faster and better and also more cost effective, because it costs less to employ a nurse practitioner than it does a primary care provider, we need to change the model. And, you know, I always look under my car with a mirror before I start up the ignition because medical associations across the country. This article in the Globe and Mail that described a problem with committing to primary care provision being family medicine in Canada, this had by far the most comments of all the 11 articles we published in the Globe. And the vast majority of them were from physicians across the country. And the vast majority of them wanted to bomb my snowmobile. You know, there was no question. This was a topic that was, the commentary being my disrespect for physicians is obvious. And this is part of the reason that family doctors don't want to be in their offices is because they're being disrespected. Well, in point of fact, family doctors can provide great care. But they're also trained to do other things. So primary care docs are trained to work in emergency departments where we need them. They're trained to look after long-term care homes. They're trained to serve as hospitalists looking after hospitalized patients. So family doctors, and I'm going to use the labor management term, not the policy term, they can make money in a bunch of different ways. And in many parts of the country, the amount of money they can make is much bigger outside their office than it is inside their office. Ontario probably leads the country in paying attention to the type of compensation system that family doctors say they want. And that is, they want to leave the fee-for-service, rat race, as they call it, where we got to see people, churn people through our office. We'd rather be responsible for improving the health of a set number of patients, pay us for looking after a set number of patients. And Ontario's moved to that model. It's called the Family Health Organization for about half of the primary care providers in the province. The problem is that we didn't put a set accountability over the amount of time that they had to spend in the office in order to generate that income for a patient. So the average doc looks after about 1,300 patients. So they sign up about 1,300 patients. That number is going down. In return for that, they make just over $400,000 for looking after that group of patients. They have to pay expenses from that. So they probably pay tax on about $320,000, somewhere around there. But the Auditor General of Ontario has looked at the time they spend in the office. They spend 3.4 days. So, the average Canadian, 3.4 days a week to earn $320,000? Would you take that, Joel? In a moment, right? In a moment. So we need accountability. This is gradually changing. We need to have new doctors coming into practice don't want to be running these small business models of fee-for-service rat race, see 7 people an hour in order to generate money. But we also need to have more practitioners, not just family doctors doing this. We also need to have full scope of practice for nurses, for nurse practitioners, a bunch of different professions who can do just as good a job. And we need to make this access better. When you call your family doctor or your primary care provider's office, you need to have access within 24 to 36 hours for certain reasons. And that needs to become the standard. And until we fix this model, our health system is going to be a concern. So that's the number one foundational problem, is how do we improve access to primary care? The second thing, and we can move forward on the slide, I'm going to talk at you for about another 20 minutes, and then we'll open up for discussion if that's appropriate, Principal. The second thing we got to do is improve access to specialists. And when our health system is ranked compared to other countries around the world, the first thing that hurts our ranking is access to primary care. The second thing is access to specialists. And part of the reason is we really have no data about how long it takes. You remember we used to have cocktail parties, right? Remember those things, cocktail parties, kind of like getting together here? When I've heard, as CEO of UHN and as deputy minister, every cocktail party I went to, people came to me to complain about the amount of time it took to see a specialist. But in point of fact, we have no data on wait times to see specialists. We have a little bit of data on wait times to get surgery, but if you're not getting surgery, we really have no data. And, that's a real problem, because when you don't have data, you also don't know the experience about how long it takes to see various providers. You don't know if you've got gaps in people providing gynecological consultations, hematologic. You don't know where your health human resource gaps are. And we have literally no data on any referral to specialist unless it's to get an operation. And that's obviously a huge problem. Surprisingly, there is an easy way to fix this, a lot of it. Right now the standard of care is if you need to go and see a respirologist for asthma, your doctor fills out a fax form, right? Usually handwritten, and faxes it to their office. And realistically, you don't know if that fax got lost. You don't know where it is in the queue of faxes that their office received that day. What do you rely on fax for? Nothing. You don't send faxes. That went out of scope 15, 20 years ago that we used to use faxes. Now everything's digital. And there are digital referral systems that download from the physicians, the primary care providers, electronic. If you do see a primary care doc, they tend to sit in front of a computer and type things into the computer about you. There are systems that send your information to a specialist digitally, securely, and request a consult. They're very cheap. They're very easy to use. They give not only a rapid transmittal of secure information, but you as a patient can then track that online and say, yes, the digital consultation request was received, the fax didn't get lost, and probably the specialist will see me sometime in this time interval. Not only that, we can then give information to health human resource planning at universities. How many residents do we need in hematology? This will tell us, look, we got a lot of people waiting a long time to see hematologists. We need more hematologists. We need more headache specialists. Right now, it's a guess. That system is cheap. It's easy to use. Government funds it. It's being used by fewer than 50%. Only about 40% of Ontario primary care docs are using it, and fewer than 20% of specialists. You know? Why, right? This needs to be a mandatory part of practice in Ontario. It really does. You know, I'm sure if Dr. Clark were to have his office would receive electronic consults and would simply create a list based on his criteria as to how soon patients should be seen. I'm sure, Howard, that would be better than receiving a fax. Is that fair to say?
We actually do it electronically now.
Do you now? Well, you're part of the minority. Thank you for doing it. Yeah, so you got data on how massive the waiting list is as well. So, you know, and SICK certainly is one of those specialized centers where you just know that they need more resources. Most of the system, you really don't know. So this needs to be there. This is part of making things faster, better. And guess what? It's more cost effective as well, because when people are waiting in limbo, again, where do they go? They go to the emergency department. I've got a terrible headache. I need to see a headache specialist. I don't know when I'm going to see it. I'm going to the emergency department. And that is a very, very common tale that people tell. The one thing, and Howard's mentioned it, let's go forward to the next slide, please. You know, you've heard about months-long waiting for surgery. Waits for surgery were bad prior to COVID. They're certainly worse now. We don't know how bad because we don't have that electronic digital data on how many people are waiting. But the estimate is there are probably 250,000 people in a queue somewhere waiting for surgery. And what if I told you there was a way to do 30%, 25 to 30% more surgery in the same period of time for the same cost to the hospital? Clearly, you should do that, right? And the answer is there is. You move surgery out of hospitals into community surgery facilities. Now, not everything can be done there, but probably much of the surgery that Dr. Clark does and children's hand surgery could be done in ambulatory settings. Much of the orthopedic surgery people are waiting for, total hips, total knees, a lot of spinal surgery, hand, shoulder surgery can be done outside hospitals. And when you build dedicated community surgery centers, which can be in old Target stores, for example, because the biggest thing you need two things for a community surgical facility. The most important thing is parking. The ability to drop people off directly at the intake door and pick them up directly at the outtake door without going a long way for parking. And the second thing is you need a lot of airflow, which old Target stores, old Sears stores are perfect for. They have parking and they have the ability to increase airflow. But you know, again, the kind of arteriosclerotic resistance to change that exists across our system. The current government is talking about moving things to the ambulatory surgery centers, but they say we need the private sector involved to move things out. Well, if that occurs, I can guarantee you the patients who are easiest to look after, who are going to create the highest profit, are going to be rapidly moved to ambulatory surgery centers. We need publicly governed, hospitals know who can move out of their facilities into community surgery centers. There are hospitals in the province that run community surgery centers. Ottawa does, Trillium does. The Kensington Eye Center does about twice as many cataracts in a day as any hospital in the province does. So there are great examples of how we can do this. Again, this is just something that requires commitment in the leadership of our system to make change happen. 30%, American centers have demonstrated 30% more surgery can be done in the same 8-hour surgical block. if it's done with attention to rapid turnover and patients moving through a system rapidly, which you get in a dedicated community surgery facility. So there are three ideas right there for better access, more cost-effective care. Let's move forward to the next slide. Now here's one that deals with equity, because in our system, if you have a mental health problem, and God knows mental health challenges have increased dramatically during the pandemic, chances are about 85% of people with mental health issues have issues related to anxiety and depression. And the standard of care in Canada for anxiety and depression tends to be pharmaceutical. And sometimes pharmaceuticals are necessary. But publicly funded talk therapy really is difficult to get in Canada. And talk therapy is as effective for anxiety and depression, which is 80% of the issues that relate to mental health disorders in Canada, as pharmaceuticals are. And in some patients, the combination of those two is even more effective. England and Australia have introduced publicly funded talk therapy. It's called cognitive behavioral therapy. You've probably heard about this. There are also online resources for mild mood disorder, mild anxiety and depression that can be used to treat people who have this mood disorder mental health issue. And this is not provided by physicians. It's not provided by psychiatrists. It's provided in many cases by nurses, occupational therapists, sometimes psychologists. So far more cost effective than what we're currently doing today, and that is referring people to psychiatrists who really don't need to see these folks. In England, in Australia, this has been demonstrated. 6 to 12 weeks of cognitive behavioral therapy are effective in about 75% of people. When you look at the cost of what we're currently spending on mental health disorders, part of it is in the healthcare system, but that is a tiny cost compared to the massive expenditure on long-term disability spent by Canadian industry, where hundreds of billions of dollars, approaching $1 trillion according to the Mental Health Commission in Canada, is spent on people who have anxiety and depression and are no longer able to work. That presence of that cost of absenteeism, and also, you've seen a lot in the paper today about mailing in your day's work, presenteeism as a cause of industrial loss of revenue, of productivity, is something that this addresses. The amount of disability due to mental health concerns in the UK with the introduction of publicly funded talk therapy has dropped to a far greater extent than the cost of this therapy represents. And this is one of those equity issues in our Canadian health system that loses us points on international comparison. Because, if you don't have employer-provided health benefits or the money to pay for this, if your 18-year-old says, I'm going to drop out of university because I'm depressed, I'm anxious, I can't stand it, I can't make the transition, if you don't have employer health benefits, if you don't have money, chances are your child's not going to get help. Hard to find help. Universities do the best they can to provide mental health services. Not really adequate to the challenge. And this is the age when so often, this is such an important issue for universities and college, because quite often a history or a future of chronic anxiety and depression begins during that transition period where people leave home and start to work or start to go to school. And it's something we currently have no really good solutions for. So this is a big equity issue in addition to being a better, faster, and more cost-effective issue. Let's go forward. There is something that we're going to have to spend more money on, and this represents the cost. It doesn't really show up well, but I believe on this slide, there are two bars here. There's a top bar that represents home care costs. There's a bottom bar that represents long-term care costs. So this is data from Deloitte and the Canadian Medical Association. Simply look at the demographics of the Canadian population. How many people are over the age of 75? In our population today, how many people will be in each of these advancing years? And, it looks at the cost of providing home care, care in the home, and or long-term care, residential care, where so many So many residents died or were affected by COVID during the course of the pandemic. And you can see the calculated annual growth rate, the CAGR for this graph, just based on how many people there are in the age group that requires these services. The CAGR is over 5% up until about 2032. After that, it flattens out. So, you know, this aging population is not something that's going to go on forever, but it is something that we need to pay attention to for the next 10 years. We need to build more long-term care centers, obviously. Let's go forward a slide, please. You know, the lessons of the pandemic where so many people got sick in these ward rooms that had 4 people, in Quebec, 6 people living in the same room, sharing the same air. Not good for the pandemic, COVID, but also not good for influenza season, not good for gastroenteritis season. There's nothing good that comes out of putting 4 to 6 people in the same room. And certainly Ontario and Quebec need to rebuild our long-term care settings. And we also need to increase staffing to pay attention to people, treat them appropriately, keep them clean, well-fed, as they become cognitively impaired, as they become frail. We need to pay attention to long-term care. But we also need to listen to these people over the age of 75. I spent a fair amount of time talking to seniors groups, and I've never, talking to hundreds, probably thousands of seniors, I've never heard anybody say, my ambition is to go to a long-term care nursing home. Nobody wants that. Everybody wants to live independently for as long as possible, go forward. And, you know, we need to look at opportunities for keeping people independent in communities. And I'm going to propose to you a new social contract that we need to consider. We're doing some work at University Health Network now, looking at this concept of naturally occurring retirement communities, or NORCs. If you take census data and you look at the age of people and where people over the age of 75 live, they tend to live in high-rise buildings. And that's across the income demographics. Across, you know, if you're poor, you live in Toronto community housing, high-rises. If you got a little more money, you live in rental accommodation. And if you're wealthy, you live in condominiums, relatively wealthy. That's where seniors tend to live. And if we understand that, if we understand from census data where people live, there are about 700 and some odd buildings, almost 800 buildings in Toronto, the old city of Toronto, that comprise a population of over 260,000 seniors over the age of 75. And if we designed our services not to each individual in their own home, but to serve buildings like that, where people live, this concept of naturally occurring retirement communities is one that has been used to tremendous benefit in New York City and in parts of New York State, where designated buildings get tax breaks, designated buildings have different ways of service, both health and social service provision, and keep people independent longer. The average length of stay from the time somebody moves into long-term care in Ontario until they die is 18 months. If we can, and you saw that CAGR of 5.5% per year, if we change 18 months to 12 months by keeping them independent in a NORC-type facility for 6 months longer, it's a huge sustainability improvement for the system, and guess what? It also represents where people want to be, keeping their independence as long as possible. So we need to pay attention to this. You'll see some information coming out in the next few months on naturally occurring retirement communities. I think a real solution, a partial solution at least, for this demographic challenge that we're facing over the next 10 years. Again, faster, better for sure, and a lot smarter in terms of how much money we spend. I think we have one more slide. Yeah, so you can find this material and all the 11 articles on the website that I think is mentioned there. Yeah, at the top. You can find that on the website. They're all represented there. Some other things related to emergency departments, how we make emergency department care more rational, a few other ideas related to health, human resources as well. But simply to say to you, we don't need to change this system into one that becomes a two-tiered system that looks at private investment for profit as opposed to better use of the public dollars that are already in our system. Changes that can be made to make us faster, better, and smarter. And it's been a pleasure to have the opportunity to talk to you about this. Thank you very much.
Thank you. Thank you so much, Bob. That gave us a lot to think about. Would you like, I think we're going to ask you to stay here at the microphone to field the questions. And Alyssa has the microphone. Here we go.
Alyssa's got the microphone. All right, Alyssa, you're going to be running.
Yes, this is.
Anita, yes. Hi, Dr. Bell. Thank you so much. Can you offer a few thoughts about how we could implement this, how we can start to overcome the barriers to implementation, please?
Yeah, so, well, there are different barriers in every place, you know? I mean, clearly in primary care, there's a huge amount of turf protection, as well as the difficulty right now. I mean, we've got a challenge in health human resources in primary care. Physicians, we don't have enough nurses. It's a bad time to say we need to start, you know, transferring nurses out of hospital emergency departments into serving as primary care providers. But we need a strategy here, obviously. We need a strategy for primary care. New graduates of primary care across the country want to leave fee-for-service behind. They want compensated, you know, roster-based, comprehensive compensation for looking after a roster of patients. We need to say, fine, but you need to be in the office 4.5 days a week, not 3.5 days a week to earn that. And we need to also say that team-based care, where some patients are perfectly fine, not the most complex patients, but you know, people sitting in this room, not one of you needs care from a family doctor. All of you could have care from nurse practitioners just fine. So groups where people are working the full scope of practice. There are 26 nurse practitioner-led clinics in the province now. There are over 100 nurse practitioners providing this kind of comprehensive care, and that just needs to expand, partly because we need more people, also because they work on contract. They aren't there in small businesses determining how many days they want to be there. So that is a labor management issue. We need to break through with the Ontario Medical Association on accountability for rostered payment, and we need to break through in this concept, because if people listen to their family doctors, you know, and if family doctors say a nurse practitioner will kill you, don't go to a nurse practitioner. Chances are Canadians will believe them. This needs to be a collaborative approach between, and I think it's coming. It will come, but it needs to come faster.
Matt here. Just a follow-up, kind of Anita kind of almost took my question. It was a good one, but more on compensation. So obviously we hear a lot about Bill 124 and, you know, capping public sector nurses especially. But also, you know, just recently, I think on CBC's White Coat, Black Art, there was a whole thing on family practice and physicians. Basically, they call it I don't know what they call their paperwork room, but they don't ever want to go into it, because I think this talks to the cycle you were talking about in the mental health and all the other issues that are out there. People are off work, and then that creates a mountain of paperwork for family physicians to deal with people being off work for long-term disability and things. So is there an easier solution just to throw more money in just in the compensation pool alone, or is it quite more complex than that?
Well, I think it's fair to say that, especially with the new agreement that came into effect this year, the Physician Services Agreement of 2022 between the Ministry of Health and Ontario Medical Association, that expanded the scope of this comprehensive rostered payment system for physicians. Physicians are well paid. You know, $320,000 for 1,300 patients for X amount of days per week is certainly the highest in the country. I think it's fair to say that in British Columbia, where physicians are surprisingly, primary care folks don't have this comprehensive model, they're all on fee-for-service in the so-called rat race, they just increased their pay out of cycle with their agreement, their physician's agreement. I think that Bill 124 was horrifying legislation, right? It was terrible legislation to begin with. You've got folks who are in a free bargaining situation that has the Health Labor Disputes Arbitration Act, HILDA, that gives them, it takes away the ability of healthcare workers to strike, but sets up the terms for an arbitrated agreement if they can't come to a negotiated agreement. It takes years of success in negotiating the salaries of nurses and various other folks in nursing homes, et cetera, and wipes that out and just breaks that system entirely, Bill 124, that limits the increases to 1% for 3 years for teachers, nurses, other people who get public sector salaries. So that was a terrible mistake, especially since it was just at the verge, unknowns obviously to the government, of a global pandemic where you're going to rely on healthcare workers while you're telling them they're heroes and saying you can only get a 1% wage increase when inflation is, 3 and then suddenly 8%. So that was a disaster. And it's going to take a few years to recover from that. And that's part of the reason for the perfect storm. Nurses leaving their jobs in hospital because A, they're burned out. They've been asked to work a lot of overtime shifts. They've been asked to work a lot of weekends, nights they weren't necessarily expecting to work because of short staffing, because of the pandemic, and they're being told you only have 1%. So public sector workers, teachers, and nurses are pissed off. There's no question about Bill 124. And this government's going to have a while recovering from that. So that's part of the challenge. Absolutely. Dr. Clark. Terrific.
This will be casting back a ways, but in terms of efficiencies, one of the things that Alan Hudson in his day was charged with doing, and it didn't work out, was the universal provincial-wide health record to make it easy to access information. That didn't happen, as we know. But what do you think are the fundamental reasons that can't be made to happen? It can't just be dollars. Why can't we move to something as efficient as that?
Well, so as you know, Howard, there are two major health systems that are prevalent in the province. One is the hospital information system, mainly provided by big American corporations, Sick Kids. UHN has something called Epic. Mount Sinai has something called Cerner. And these are systems that not only collect information about patients, they collect lab work. They're crucial in the United States for billing. That's their main purpose in the United States, is their billing systems. But they are essential to the hospital running its business across the various areas. And then primary care providers have electronic medical records that are in the office. And, right now in Ontario, there are only 3 electronic medical records. There's one provided by TELUS, there's one provided by Shoppers Drug Mart, interestingly enough, who are really getting progressively into primary care. Makes a lot of sense for their business. And there's another one that grew out of McMaster, is now owned by a BC company. So there are basically 3 electronic medical records that are progressively more and more similar. These e-referral things that send digital information seamlessly interact with those. Please, Howard.
But none of those systems talk to each other.
Well,
So Sick Kids doesn't talk to TGH, and the one family doc doesn't talk to the other family. I mean, they're towers. Each of them are separate towers.
So the
silos.
idea, and I'm not going to defend this, but I'm just telling you the current state. You're absolutely right. The idea of these comprehensive payment strategies that if you look after 1,400 patients, you will get paid a certain amount of money, suggests that your entire group will have the same record. That's necessary. And some of the groups, Guelph has about 150 docs on it. Peterborough has only one family health team. Collingwood has. So there are some large family health teams all on the same thing. So if your doctor's not there and you're going to see Dr. Smith rather than Dr. Jones for your child's fever at nighttime, they have access to your health record. You're absolutely right that another group of physicians won't have access to that information. And if you go to the emergency department, the hospital won't have information from that electronic health record. That electronic health record will seamlessly download information from every lab test you've ever had, any hospital records in terms of consultation notes or x-rays done in the hospital, but it's disjointed. The biggest thing that's happened to enable this actually happened about 4 years ago. The government mandated, this gets really wonky, the use of something called FHIR, F-H-I-R. I don't know what the letters stand for, but it is a universal interfacing mechanism for health, digital systems in Ontario. Everyone has to have FHIR. And it has to have open data as to how to access the information. So there is more integration of information, but you're absolutely right. Not only do we need to insist that e-referral happens, we need to insist that all information systems are interconnected through this FHIR interface. It's still clunky. I won't tell you it's smooth as silk, but it's at least accessible to you. Now you can probably get now, is it fair to say that if a child comes to see you, I don't know whether cleft lip, does it require a CT of the facial structure? No. But you can probably get access of x-rays from other hospitals.
It's scattered. Sometimes yes, sometimes.
Sometimes yes, sometimes no.
In terms of cost efficiencies, we're sometimes sending someone for a repeat x-ray,
Yeah.
which was done a few days ago. If I could simply see the x-ray from a few days ago, we'd be fine.
Well,
so that's costing us money.
So there you go, because the systems that transfer digital x-ray are available, but again, we need the mandate to make that happen. And when Howard and I were both young, there was a system brought in Ontario for wait times for surgery. Not so much in kids, but in adults. 2001, the government said, we need to collect data on wait times. And doctors said, oh, I'm not going to enter that data, forget it. You know, you need me more than I need you. So then the government said, unless you provide the information for wait times, when you're registering that patient for surgery and when that surgery gets done, you cannot get access to operating room time in the hospital. Well, guess what? 100% of surgeons started entering that data and we should be doing the same thing with e-referral. We should be saying, a year from now, 18 months from now, unless you refer patients by e-referral, the specialists will have a discount on the amount of money they get paid for that referral. You know, we need these mandates in place to make stuff happen. Because physicians are wonderful people, but they have their own businesses to worry about. And they're not necessarily going to change something that, let's face it, is working for them. If you have a 2-year waiting list to do your total hips, you'll just keep on doing your total hip replacements. You don't necessarily want to have a system introduced that takes some change in your office to shorten that wait list by electronic referral mechanisms. What about you junior fellows who are all working around the healthcare system today? Is this discouraging or can you see opportunity here? Come back to you.
One of the questions that I had, I'm a junior fellow, but I'm not in the kind of area of healthcare or medicine, but you were talking about the e-referral system just now, and I'm wondering, because the calculus seems so clean to me, as someone outside of it seems, faster, better, more cost effective, but
Yeah.
So then what's the reason that there isn't a buy-in right now? And I think you just touched on it a little bit, but I was wondering if there's any data or analysis on why physicians aren't taking it up currently.
Yeah, pure, utter inertia. That's the only reason. Howard?
Plus the separate factor, which I was already talking about, is that when you want to send your electronic referral to sick kids, you have to log in, set up an account, sort the whole thing out and use the sick kid system. When you want to send your next patient to TGH, you have to produce another account, and we've all been through this with retailers where each one wants its own things and a separate one. So again, if it was truly universal, one entry point across the province, then bingo, would be very easy to mandate.
Well, this e-referral system is universal, and what happens in it now, sick is obviously a special situation, but UHN is coming to use the e-referral system, I understand. And this system is universal. It sends the consult to the next available person with the appropriate credentials to actually see you, someone who does total hip surgery if your problem is hip pain. So referring to sick kids is a different issue, but the average consultation, you don't need to sign on to a different system. You can use this, it's called Ocean referral system out of your electronic medical record as a primary care provider. Jane has a lot of interest around primary care, so over to you, Jane.
I do. Thank you so much, Bob. This is a really interesting talk, and I feel like I agree with your points. I think to your first point about not every Canadian needs a family doctor, I was thinking about this, and I think one piece that I didn't really hear you expand more about is education to the public and education to healthcare providers around who can or does provide appropriate care. And the example that comes to mind is in 2017, we expanded the scope of practice for nurse practitioners to be able to provide opioids and prescribe opioids. And on the surface, that seems like a great thing because it suddenly means that nurse practitioners can take over this one piece of practice from family doctors or perhaps share that responsibility. And yet, so many nurse practitioners went into a panic and they said, no, we don't want this responsibility. Even though we can actually prescribe, we won't do it. And I think about that in the sense that, if there are suddenly nurse practitioners who have expanded scopes of practice, who can provide the same level of care, who are practicing independently, perhaps in smaller towns, not necessarily Toronto, but more rural and remote areas of Ontario, I think there's a lot of education and attitudes that need to be overcome around that. And so I wanted to hear a bit more about your perspective. And then a second question was around just what are your thoughts around Ontario health teams and that current, we'll start with
So let's talk about scope of practice. That essentially, that's, bureaucracy talk for what can a provider give you. And that's not determined by the individual. That's determined by our colleges, right? So nurses, physicians are regulated health professions, and their scope of practice, what they can and can't do, is determined by the government through legislation that then provides authority to interpret that to the colleges. And nurse practitioners, as Jane said, have been given the ability to prescribe opioids. So some of them don't want that, but then again, lots of primary care docs don't want that either. They don't want to prescribe opioids because, they're aware that the college looks at opioid prescriptions that maybe give you 3 opioid pills, something like that, because of the concern about creating addiction, which is an appropriate concern. My sense is that the scope of practice for nurse practitioners, to use an example, is appropriate to office practice. They can't go and admit patients to hospital. They can't go and see patients in emergency departments, generally speaking, unless they have special hospital privileges that family doctors can do. So it's not the same practice, but within an office practice, which is where 90% of our healthcare encounters occur as Canadians, right? Most people aren't going to see a surgeon every day. They're seeing their primary care provider. And you're right. I mean, education as to what folks can accomplish. Right now, most of the education we get as to who can do what comes from medical associations. If we look at the actual pragmatic practice of care, the further you get from healthcare resources in Canada, the higher the likelihood you're going to be looked after by a nurse. Not a nurse practitioner, but a nurse. So if you look at the 26 communities in northwestern Ontario, in the NAN Confederation that relies on Sioux Lookout as its primary care hub, those aren't nurse practitioners looking after, up to 2,000 people in those communities. Sandy Lake, a variety of communities up in northwestern Ontario. Those are nurses. And they're trained in primary care, and they're providing, in many cases, great jobs, backed up by telephone consultation from the physicians at Sioux Lookout. But in Canada, your scope of practice is largely determined by turf setting rather than by public education or by college regulation in terms of the pragmatic aspect of who provides care. And it relates to money more than it does to policy. Your second question.
Was around Ontario health teams.
Yeah. Well, I think they're essential. So Ontario health teams are a construct of this government saying we need to get better integrated care in the community. So, the average Canadian doesn't know where they go for what, right? Don't know how do you get mental health services? How do you get home care? Like, who knows? So the idea is to have an integrated hub of services in the community that is largely based around primary care. So your primary care provider would be your navigator, would say, for mental health, now I think we need to have this access to publicly funded mental health talk therapy that I was talking about. But right now, that doesn't exist, and if it did exist, you wouldn't know how to get there. So to have integrated services, primary care, mental health care, home care, access to long-term care, community support services. How does your grandma who's failing, she needs transport to medical clinics. Is there any partially publicly funded assistance that she can get? The answer to that is those services in the community need to be integrated. People need, going back to Dr. Clark's point, need to have health records that intersect so that a home care provider can see what the primary care provider's advice regarding the patient's congestive heart failure is when they're in the home with the patient. The government has declared a policy of Ontario health teams, but again, it's the issue of a mandate. They've said to these Ontario health teams, figure it out and do what you will, essentially. They haven't said you must do this, that, or the other thing. Say, figure out who you're looking after, figure out what areas of interest you have, and do it if you want to do it. And they don't say you got to take your budgets and combine them. They don't say you got to make health records accessible to all. They've sort of made it a integration that says, give it your best efforts. And again, that lack of mandate just doesn't work. So I just did a thing at Rotman School. We had a group of Ontario health leaders in, and we did a morning on Ontario health teams, and we did breakout groups. These are hospital leaders, healthcare leaders from across the province. How well is your Ontario health team working? And the overwhelming, virtually unanimous opinion was, well, they may be working as talk shops to let us compare problems, but they certainly don't fix any access problems. So the government needs to change its policy on Ontario health teams if this is going to work. And they got to say, you got to do this. Can't be just best efforts.
Thank you for your talk, Dr. Bell.
Pleasure.
So my question is, I think after learning from the pandemic, we're really good at adapting to new innovations when we're faced with no choice. One of the things that you brought up in your talk was surgical centers really quickly adapting to moving things that was procedures that were mostly in the OR to outpatient settings. And so informed by my own experiences as sick kids, I noticed that same trend. So looking into the literature, you see a lot of great environmental scans being done, saying how this is feasible and how we can actually make this like actual policy change. But these types of environmental scans, this type of literature is never really taken to the policy change makers. They don't really act on this type of body of literature or this research. So my question is, how do we bring this type of work that's been proven to the people who actually inform policy? And my second part to that question is, do you think the federal government should play a stronger role in mandating policy across Canada?
So if you look at the way our system is organized, and I can tell you from working on the inside of our system in the province, I mean, the boss of the system is the Minister of Health, right? And we've had some wonderful ministers of health. We've had some ministers of health who know absolutely nothing about healthcare and no idea about how to make a system work better. And their bureaucrats oftentimes are expert. Certainly the bureaucrats we have in Ontario today are extremely expert. But are they listened to? I don't think so. Are they trusted? I don't think so. Are they allowed to put in place a if you're running a corporation, you put in place a multi-year strategy. The problems we have today are no different than the problems we had 15 years ago. Access to primary care, access to referrals, access to surgery. The same problem. Has there been a multi-year strategy that says, here's the steps that we need to take to make this happening? If we were a company like the for-profit companies in the United States, I'm not in favor of for-profit healthcare, but there are organizations like the Cleveland Clinic, Kaiser Permanente in the United States that provide better care than we provide because they have a corporate structure with a corporate strategy that says, if we're going to make more money and if we're going to have more people bring their insurance to us, we have to provide better care. And that is the one problem with our universal health system. It's run by people who typically don't know anything about the system they're responsible for running. And that's a challenge. When we get the occasional minister who will listen, the government that will listen and trust its bureaucrats, progress can be made. But sometimes that doesn't happen.
Thank you for your excellent talk. The model you propose has many aspects, and all of them seem extremely rational. Now, in order to be implemented, there must be some mandate from somewhere that imposes that. I'd like to know, where do you find the resistance? What do you do to overcome the resistance? Is there anything that can be done? Because unless it's legislated, all will be pie in the sky. I mean, I think that everyone around this table agrees that the model is wonderful. Now, in order to be implemented, you need to have it, you need to have the other side accept it. What are you doing to overcome the resistance?
So
is there
mind
anything
you-
we can do to
Yeah,
help?
there is actually. I mean, the reason why we put these articles in the Globe and Mail, and they had good response in the Globe and Mail, the reason why myself and co-authors are wandering around talking about this is that Canadians need to start saying, governments, why aren't you doing this? Why are we accepting a primary care system where 50% of Canadians either don't have a primary care provider or can't get in to see them within a week? That needs to change. Citizens need to become educated about the dire straits our system is in many ways and start demanding change. All these things, I can tell you, and I'm not being partisan here, I'm not a politician, but all these things were en route prior to 2018. We had community surgery centers being developed. We invested in this e-referral system. We were talking about bringing more nurse practitioners into primary care. We were starting this mental health program, and two things happened. One was a change in government. The second was a pandemic. Now, the government couldn't do anything about the pandemic. But you're right. Canadians need to say we're complacent about our healthcare system, and we can't be. If we're complacent, we're going to end up with two-tier medicine, because the people in this room won't accept the poor quality of care they're going to get, and they're going to say the easiest thing for me is to pay out of my pocket. I want two-tier medicine. That's what's going to happen. Anyway. There you go. How's that for a note to end on?
That's quite a sobering note to end on, but you've given us much to think about, and we're very grateful to have you here at our inaugural lunch. So thank you so much for coming. If you could all join me in thanking Dr. Bell.